And I want to thank Jim and thank Connie. And as Connie mentioned, it was my pleasure to join the Academy in January after 20 years of practice management experience in academic and private practice settings, in addition to regulatory and legal consulting. Connie has provided the legislative and program overview, and Jim has just presented the legal parameters and consideration. Now, Brent and I are going to drill down a bit more to the operational and financial levels. First, in terms of backdrop, after the legislation passed last year, the Academy had the opportunity to provide recommendation regarding the financing and payment methodology. And these recommendations are here on this slide. As has been mentioned, at the reconciliation time, CMS will take the 5% of savings off the top as is legislatively required. The Academy also recommended that there be a funded demonstration cost outlier pool, that Medicare payments on a fee-for-service basis continue as they are now, that there be a chronic care coordination, periodic per beneficiary per month payments, that there also be afterwards in a review of the savings, an 80-20 split of the residual shared savings, a net of the mentioned 5% and the above periodic payments, with 80% going to the IAH medical practice and 20% being returned by CMS. And finally, in this last point, the Academy also recommended, and this might be introducing a new concept, that the hierarchical condition category, or HCC, risk adjustment model be used for financial performance analysis. In short, the HCC model is a model used to predict risk and cost on a group versus individual basis, and yet at the same time is used to provide adjustment at the individual level so that those responsible for the financing and delivery of care are not incentivized to take on the least sick, nor are penalized for caring for those with multiple chronic diseases and are the most sick. This model begins with ICD 9, presently code assignment, without regard to site of care and without regard to the site of the code origination. This model, developed about 10 years ago, was implemented in 2004 for the Medicare risk program that is now the Medicare Advantage program. And we will post a primer or link to the primer by one of the architects of the HCC model on the Academy site in case this model is adopted in the regulations. And this HCC background will also likely be helpful in your discussions with health plans and other payer organizations. So those are the recommendations made to CMS, and as we await for the regulations to, again, be presented. However, we also know that RTI, the contractor, who was engaged to advise CMS on the methodology, payment methodology, has taken a different approach to payment in other demonstrations, with payment reconciliation at the end of demonstrations with varying amounts of shared savings. And also, they have in the past not provided or recommended for periodic payments related to the increased demonstration model requirements and cost. Going on to some of the next slide and the key considerations, as Connie and Jim have also mentioned as well, does your program already have the requisite capacities? And so the build and cost of the capacity build would be minimal. Are you already providing care under the required model? And so the IAH medical practice model would not reflect change in practice style or comprehensiveness of care. Are you able to handle the increased and ongoing cash flow requirement? And Brent will further detail these requirements. If you're not able to absorb the increased cost of business that this model represents, and absent any periodic payments from CMS, then you want to begin your discussions now with your local and other potential sources of funding to eliminate this gap in operational funding. Some of the other key considerations you want to consider are, what are your financial incentives to clinicians and other members of your comprehensive team? It's difficult, as we know in the practice world, to manage mixed message models. For example, comparing the unfettered fee-for-service productivity environment vis-a-vis a managed care and shared savings model that emphasizes care coordination. And we're seeing this emphasis on care coordination more and more, and the Academy is currently conducting a review of the Medicare fee schedule for next year, and we see a lot of requests for comments on care coordination and the payment for related to care coordination. So, for example, do you have a compensation methodology in place that provides for a base comprised of a guaranteed portion with an at-risk portion of clinician compensation that would be subject or at risk for some of the measures that Connie has already mentioned, such as patient-caregiver satisfaction, coordination of care, communication, quality measure reporting, the documentation and coding to evidence the severity of your patients that would then feed into the financial assessment. And we have previously worked on such compensation methodologies in prior experience. And beyond IAH considerations, if you have not touched your compensation methodology for your employed or your independent contractor clinicians and your allied health professionals, then this would be a good time to do so. The analysis specific to your market, the necessary discussions with clinicians and funding sources, and the contract drafting takes time. So you want to review this area regardless of IAH application. And this is an area the Academy can help from a consultative perspective. Now, I'll turn things over to Brent to continue now and review the practice operations and financial considerations for your construction of an IAH medical practice.
Thank you, Gary. As Connie mentioned early on, my name is Brent Furane. I'm president of Colonnade Healthcare Solutions, and we're a consulting firm that helps health systems, larger medical practice, home health agencies, managed care organizations develop post-acute programs, among them house call programs and IAH-like programs. As Gary and I were putting together these slides, we thought a great place to start would be a baseline. If you, once the RFP is issued and we understand the requirements to propose to be an IAH organization, where are you starting right now? And I think this is a good time to take a critical look at your foundation. So going into some broad categories here, we're first looking at your care that you're currently providing. So we're providing in-home primary care and education to a patient base that includes IAH-eligible seniors. That will need to grow to a panel of 200 IAH-eligible seniors. Not all of the panel would be eligible today, most likely, by the criteria. Now, you want to be coordinating care for that group of patients. You're better positioned to prepare for IAH if you're currently coordinating the specialty care and diagnostics and home health, in addition to working with community resources on psychosocial services. Those psychosocial issues can significantly impact your ability to deliver care. So you're better positioned if you're beginning to build from there. A position that's still tenable, but might be a bit more work to be IAH ready, would be if you're merely coordinating your specialty care and diagnostics for your patients. Similarly, in an EHR situation, if the system is installed in your practice, it's in use, you're comfortable with it and you're utilizing it, that's a very solid place to be. And you can then add the requisite needs to be an IAH organization. If you are not using one right now and are just entering the system selection phase to be implemented, that's a lesser position. Not that it can't be done, but it would be a little bit more effort to get ready for IAH at this point. Quality outcome satisfaction, there's been some discussion of the reporting, the measuring of the data, the reporting, whatever requirements the Secretary will mandate. If right now you're currently measuring a limited subset of information, that's great. I would hope that at least you're looking at designing those programs now as a minimal position to be in order to be ready for IAH. not knowing the standards to be issued, but I would think that you would at least have a program designed and ready to implement, if not already looking at the data and adjusting your practice style to it. Team-based approach. Ideally, you have some form of team collaboration, interdisciplinary team meetings with another clinician, another provider in the practice. Lesser position would be if you're a solo person who's not accustomed to regularly collaborating with other care providers in a team-based concept. And then office operations. If you have an office staff that's able to support you, provide scheduling, limited care coordination, some financial analysis of your expenses, some informatics on your utilization, that would be a very strong position to be in. A lesser position would be a more less sophisticated office staff who may be just doing basic practice reporting on productivity and a profit and loss sheet. Now, the next two slides, we're going to go through necessary add-ons to be IAH ready. And as it's been alluded to, you should be thinking larger than IAH and Medicare, albeit a worthy demonstration. There are particularly Medicare Advantage plans that are very interested in IAH-like programs because while their case management has been effective to a point, they struggle to manage that top 5% that Jim referred to. So these types of programs are attractive not just to be prepared for the demonstration, but also to be attractive to other insurance options. So first one is, as I mentioned, you're probably caring for people that are clinically appropriate to be in the home. They may not all meet IAH criteria. So your ability to case find, to get referrals, to identify those patients that would be IAH eligible, that's an important function to add, and you want to get to that 200 mark. 24/7 coverage and coordination with facility-based care providers. That's a little bit more of a stretch for a lot of house call practices, provider at this point, where you're providing care 24/7. You want to prevent that ER visit. You want to be able to receive someone after they've been discharged and get care in there in a timely manner. So you need to be able to coordinate with the facility-based care, including skilled nursing facilities and hospitals. In addition to having the EHR EMR capability, you have to be able to integrate remote monitoring for vitals, monitor patient development so that you can kind of prevent an admission, prevent an ER visit by possibly making a home visit, and integrating mobile diagnostics so that the data is part of your medical record. Quality outcomes satisfaction. You're going to have to be able to be at a level where you're tracking, analyzing, reporting the quality and outcomes data mandated by the Secretary. That yet to be defined. And then be able to, in real time, adjust your practice protocols, your office operations, your standards to respond to the data, to enhance satisfaction, to enhance outcomes, and to create the savings that you're striving for in the shared savings. The comprehensive team-based approach, you need to have an interdisciplinary team, which includes disciplines outside of medicine. It's going to include social services, access to pharmacy, home health. PALMed is often important. So these are disciplines that the program may not be regularly, weekly interacting with. There are options for building those disciplines. Doesn't necessarily mean you need to hire. There are community service agencies that will collaborate with you on the social worker side. The local pharmacy, if you're using them as a home delivery pharmacy, will often have a pharmacist dial into your team meetings. There are options. We talk about the weekly interdisciplinary team conferences, integrating other providers, and then office operations. In addition to what you're doing now, you're kind of stepping up your game so that there's fairly robust financial and accounting capabilities. So you're monitoring expenses, you're looking at clinical outcomes, you're looking at data, you're looking at revenue, cash flow, because you'll be investing most likely in your practice. While there may be some organizations IAH ready, for most that want to apply, they'll be investing here, and there'll be a need to keep tight watch on the investments, the expenses, the data, the outcomes, to make sure this is a positive experience for the practice and the outcomes are reached that are desired. Now, this is a kind of two extremes. You know, in my work, you come across a traditional practice there, and then a more coordinated practice integrated into a health system. I'm just trying to contrast here. Most practices probably lie somewhere in the middle. But in here you'd see a small solo or two-person house call practice serving 250, 300 patients. They may be on a medical chart or implementing or currently implementing an EMR. There are, I've chosen health system, but there are also other larger, sophisticated house call programs who would have an enterprise electronic health record that integrates home health, lab, the medical practice, the hospital side. Access the data in a very timely manner that way. Referrals often are informal through word of mouth, community resources. Here there's almost case finding using the electronic medical record and case management capabilities. Diagnostics provided by a third party that would now in IAH need to be integrated in the system. It's part of the capability of the system. Often they'll take their own call or share a call with another house call practice. That puts a lot of pressure on the 24/7 coverage that will need to be addressed. In the larger systems, that call would be shared and rotated among multiple community providers, NPs, physicians, PAs. You admit to a hospital or SNF of the patient's choice. Here we're typically admitting to an affiliated facility with information provided to the admitting physician so that care is more seamless. You know, there's an expression some of the physicians I work with, it's called, instead of post-acute, pre-acute. You have to prepare to submit to get them into the facility because so often the facility can undo the hard work the house call practice has done. So that linkage there between the practice and the facility is very critical. While the patient is in the facility, the solo doctor, the solo practice, the smaller practice is likely not doing discharge planning on that patient to understand when they're coming back, under what conditions, and what will be needed in the home. In IAH, you're going to care very much about when they're coming back to their place of residence, in what condition, with what technology, and when do you need to see them. And then oftentimes there's no meetings in these smaller practices because they're all busy seeing patients. And in these larger systems, there's support there to provide for weekly meetings with the appropriate specialties and ancillary providers around the table. What this page here is, you know, people will come from many different spots to get to IAH preparedness. So what we've done here is we've organized the buildup of what it may cost you to become IAH ready by the categories of the legislation. You may well have some of this in place already. You may need to add it. In some areas it's kind of open, so we're not quite sure how to set a range, but in the categories we're using here, you may need to add another medical provider, and there's a cost to that, MD, MP, PA. You may need to add a social worker, and that's if you need to employ them, or you may be able to use a community resource. I have some clients that are actually leasing social workers and RN case managers from community service agencies like Area Agency on Aging for a flat hourly rate. It keeps their costs down. They just kind of pay for what they need. A pharmacist, we talked about that, and how you can access that through a community organization, through the community pharmacy. 24/7 coverage, that's going to be really open. The cost of that is dependent upon your staffing, the call group you're in, what you need to add, and then an IH coordinator. I don't know. I think this person needs to be part of the practice. It needs to have the sophistication to coordinate care, almost like a triage RN that understands clinically what the care that needs to be delivered and can help the providers be very productive and efficient. Information technology, really from where you start, you need to establish those linkages with other entities that you'll be using, diagnostic capabilities, et cetera. And there's phone communication depending where you start there. And if you don't have an EMR, these are some minimal numbers to use some of the more commonly found house call specific EMRs today. Reporting outcomes, it's open depending where you're starting at and what capabilities your office staff has. You likely don't need hire an accountant or anything up to that level, but if your office manager has the capability of doing some reporting on whatever system you're on now, you have to be able to understand the financials of this arrangement, and if there is a per beneficiary per month fee, be able to manage that, report on it, understand it, and then establish, if there would be this beneficiary payment, the appropriate financial reserves and protection to pay that back if savings aren't achieved. And I know the Academy's done some research on options there, among them a bond that can be purchased for a single-digit percentage of the reserves you're insuring against. So the Academy can provide support and assistance on that. And then there's some other hard or soft costs associated with the build. Are you going to seek professional assistance in legal operations, clinical program development, or build yourself? Do you need to add space for the additional staff or capabilities and practice providers? And then you'll need working capital to help take you through at least the first 90 days, even with a per beneficiary per month fee for costs and expenses and cash flow. So depending on where you start, the cost to build this could be in that range, $100,000 to $200,000, depending on where you're starting and what you need to build and where you need to get to. With that, I'm going to turn it over to Gary to talk about some of the services and capabilities the Academy can provide.
Okay. Thanks, Brent. And as we have a number of great questions we received that we want to get to. And as Connie, Jim, and Brent have reflected, the Academy has resources to help you assess and develop this opportunity and beyond this opportunity in IAH-style medical practice that will be useful for other payers and markets as well. Resources, as mentioned, include the field guide, including the recommended clinical guidelines, the regulatory analysis and advice we will develop once the regulations are released, and the ongoing practice management services of the Academy. We have time for questions, and if you need to jump off, please stay tuned for related information, and we do hope to see you September 22nd in Washington. And with that, I'm going to turn things over to Connie for us to begin to address your questions.
Thanks so much, everyone. Well, we've got a lot of great questions and 10 minutes to try to fit as many in as we can. I have grouped the questions so that we can go as quickly as we possibly can into ones that I can answer about what we know for sure and what is going to have to wait for the specifications. And then I have questions, Jim, for you, and one for Brent and Gary that hopefully we can get to talking very fast. First of all, I got a bunch of questions about, what about this, what about that, that are in the that will be in the specifications. The question, and I'm going to just list them. The question of whether HCC scoring is going to be required, remote monitoring, what satisfaction survey providers are going to be used. All of those things are going to be in the specifications, along with how the savings attributed to the savings are going to be attributed in the case of a patient served by multiple providers. Overall, you should just know we've made recommendations in all of these areas. Whether they'll be adopted or not, we just don't know and won't know. Same thing on periodic payments from CMS. The question, Teresa, about new patients versus existing, our recommendation is that these are patients that you would bring forward. However, what CMS comes up with in the end, we don't really know. Do EMRs need to be certified? We can only guess probably, but we won't know that till the specifications. What quality measures should be monitored now because they're likely to be in the specifications? We've made recommendations. I would not do anything new until the specifications come out. And on the issue of whether identification of participants will be by you or by them, we won't know. We certainly have made recommendations that they would be from you all. So that's a group of questions that I can answer. Now, Jim, I have two for you in a small number of minutes. One is, will IAH patients be brought under an ACO? The other is, what are the services that are subject or could possibly be in breach of stark anti-kickback or corporate practice of medicine that are involved in IAH?
Well, in the first question, there can't be a mixing of ACOs and independents at home programs under the IAH demo. The programs that operate under the demonstration cannot also participate in an ACO, but if they have a separate ID number, if your practice has a, or group practice has a separate ID number, then it can operate as a independence at home organization, still under the umbrella of an ACO, but it wouldn't actually be participating in the ACO, and the patients it treats would not be participating in the ACO. They would be only eligible for the IAH program. But if you have an independence at home program that is not participating in the demo, then certainly it's available to participate in virtually anything, Medicare, Medicaid, or private insurance. The second question: what issues could run afoul of Stark and the anti-kickback law?
Right,
well,
that are involved in IAH, right?
That are involved in IAH. Almost anything could run afoul of the anti-kickback law. But it has to be a designated health service for Stark to apply, and you want to make very sure, particularly if you're operating in the demo, that you are providing home-based primary care services which have not previously been covered by Medicare and are not a designated health service. We would recommend that you do what you can to come also within either a safe harbor to the anti-kickback law or an exception to Stark, and there are ways to craft the agreements to do that.
Great. Well, thanks so much, Jim. Okay, Brandon, Gary, considering the significant barriers to entry within all payers, how do you suggest approaching payers to enter into shared savings opportunities? Contracting departments are generally not able to go beyond the traditional fee schedule.
Right. The successes we've had have been through a medical director, and it's been through a conversation of a house call physician who understands what can be done and brings data to a medical director at a managed care organization and explains how these results are achieved and what's necessary from the house call practice and what's necessary from the managed care plan to get there. The conversation has to start there, in my opinion, and then they can go to contracting, case management, et cetera. But it's got to be, in my experience, a physician-to-physician call first.
Mm-hmm. Well, on this one, I would just add, since Kevin's not on the call, another strategy that has worked for at least one of our members who's been at this for a long time is to start with what they can deal with. So, for example, this is a member who's in Arizona. He has 3 different fee levels, one for the very sickest patients, then for a middle group, and then I believe one for the less expensive patients. The one that includes all care coordination and everyone for those patients is high enough to cover his cost plus. And because that is a model of capitation contracting that is within what they are familiar with, he has been able to negotiate contracts directly, but they are different payment levels for different sickness levels. It's not exactly shared savings, but it certainly is giving him more money for doing more difficult patients and more work.
And Connie, I would just add, to make sure folks understand, they have a lot more negotiating latitude under an IAH model in a private insurance program or perhaps even Medicaid than they're likely to have under the demo.
Right. Last question, and we've got 5 minutes. Can someone explain what was on the slide? Funded demonstration cost, outlier pool for Teresa and others. All of that terminology relates to the proposal that we made to CMS, and I'd be happy to share any of it with you. I think for the purposes of the people on the call, though, they simply need to understand that while we made a proposal, the question of whether RTI, the CMS contractor, and what CMS will finally adopt is what we really need to focus on at this point. We thought it was a perfect, wonderful proposal, and the people who worked on it we thought were brilliant. But of course, you know that that's what we can do, and we can't know what else is going on. But I'd be happy to share that with anybody who is interested. So we are at with 4 minutes to spare, I think. And with that, let's just talk about where we go from here. First of all, we're going to accept Jim's question, Jim's great suggestion, and we're going to start a frequently asked question portion of our website, so please stay tuned for the notice on that. Stay tuned for the notice on September 22nd. That will be coming out very shortly, and we hope that those of you who are interested can come to Washington and participate in that day, which will also, by the way, talk not just about the demonstration, but give you a chance to hear about some managed care numbers as well and Medicaid as well. Also, I want to be sure that you know that if there are any of these resources that we've mentioned to you that are of interest to you, they are available to you on our web, the hard copy things as well as the practice management and technical assistance services. And with that, I want to thank you so much for participating in this first IAH webinar, and I will bring it to a close with many thanks again to our presenters. And if you have any questions or suggestions, you know what our email address is, aahcp@comcast.net. Thank you very much.